Hello. Hello, Dr. Havelia, sir. Am I audible?
Yeah, you are audible.
Sir, next is your session.
Yeah.
Would you like to check the screen share once
Yeah,
before starting the session?
Yeah, I would like to check that.
So you are not. Can you hear him?
Yeah, I can hear you. Should I share my screen?
Okay, sir. Once please give a trial. Screen share एक बार करके देख लीजिए. Then we will start the session. Okay.
Just let me go to the background once.
Off करा है sound.
Yes. Should I share the screen?
Yes, sir. Yes, sir.
Yes. Is it visible?
Yes. Yes, sir. Visible. Now please stop sharing. We start the session formally.
Fine.
Okay, sir. Thank you, sir. Thank you.
Thank you.
Ma'am, we can start the session. Shreya, ma'am.
All are there. Dr. Manobruto Mojumdar and Dr. Shanta Ghosh. All are there.
I'm calling them, sir. All are joining. Dr. Pradip Laha, sir, is here.
Yeah.
I can see.
Dr. Ghoshal.
Dinesh, hello.
Hello.
Shanta madam is also here, ma'am. Sorry.
Hello,
Fine.
Dinesh. I'm joined.
Yes. Welcome, Didi. Welcome.
Welcome. Okay.
অশোকদা কোথায়? অশোক ঘোষাল
দেখা যাচ্ছে?
দেখা যাচ্ছে।
দেখা যাচ্ছে তো?
looking handsome.
Welcome. সকালে
Afternoon. Good afternoon, everybody. Good afternoon.
দিদি ভালো আছো? বহুদিন পর দেখা হচ্ছে। বহুদিন পর দেখা। তুই কোথায় বেলেঘাটে?
শরীর খুব একটা ভালো নেই। আমার তো একটু এট্রিয়াল ফিব্রিলেশন, হার্ট রেট বেড়ে যাচ্ছে ভীষণ। এট্রিয়াল ফিব্রিলেশন আছে তো? আমার তো এট্রিয়াল ফিব্রিলেশন আছে, একটু অসুস্থ। ওই জন্য গেলাম না। তুমি বলেছিলে যেতে, বেশি ট্রাভেল করছি না। যাই হোক, তোরা সব ভালো আছিস? ঠিকঠাক?
Sir, ma'am, am I audible?
Yeah, you're audible.
Sir, আপনি আপনার যে প্রেজেন্টেশন থাকে কোন আপনি একবার শেয়ার করে যদি দেখে নিতে চান এখানে?
একবার দেখা হলো।
দেখা হয়েছে তো স্যার? সব ঠিক আছে তো?
সব ঠিক আছে, সুপার।
আর স্যার বাকি প্যানেলিস্টদের কি কোনো কিছু আছে প্রেজেন্টেশন বা কিছু দেখানোর জন্য?
জাস্ট প্যানেল ডিসকাশনই আছে।
ওকে। ওকে স্যার, ঠিক আছে। তাহলে
অশোক ঘোষাল এন্ড ডক্টর মানবদা জয়েন করেনি এখনো।
হ্যাঁ, ওনারা আছেন, ওনারা জয়েন করছেন স্যার।
পার্টিসিপেন্টস খালি 12 কেন? ওই হল এতে 30-35, এখানে 12-15।
অ্যাকচুয়ালি এখন আমরা টাইমের আগে বোধহয় স্টার্ট করছি, ওই জন্য।
না, এই জন্য না, আগেও সকাল থেকে দেখছি।
আচ্ছা স্যার, আসলে এখানে কুইজ পোস্টার, হ্যাঁ স্যার, কুইজ পোস্টারস ওগুলো হচ্ছে তো।
And so many webinars are going on. It's a pandemic of webinars.
Yes sir.
বা তোমরা যা শিখে বেরোচ্ছ আর পারা যাবে না।
এখন তো স্যার নরমালাইজ হয়ে আসছে না।
দিনেশের পেছনে এত বইপত্র দেখে আমার তো একটু ভয় লাগছে। দিনেশ কি সব পড়ে এসেছো না?
এগুলো
পেছনে বইপত্র একবারে ভর্তি।
এগুলো পার্ট অফ দ্য ফার্নিচার।
পার্ট অফ দ্য ফার্নিচার। যাই হোক, তাড়াতাড়ি আরম্ভ করে তাড়াতাড়ি শেষ করবে।
আমাদের তো গল্প হবে।
হ্যাঁ, অনেক বিকেলে অনেক কাজ লাইন আপ রয়েছে, আর শরীরও ভালো নেই একদম, একটু হার্ট প্রবলেম হচ্ছে তো। যাক, নাইস সিইং ইউ অল।
হ্যাঁ, ইটস গুড।
কোথায় গেল আমাদের বড়? ওরা তো আমাকে তাড়া দিয়ে বললো অশোক ঘোষাল স্যার এসে গেছে।
না, অশোক দা তো বোধহয় অফিসেই আছে, জয়েন করবে।
হ্যাঁ,
উনি অফিসেই আছে। অশোকদা বোধহয় মানবদাও বোধহয় অফিসেই আছে যতদূর জানি।
যথারীতি কারোর মাস্ক পরা নেই দেখতে পাচ্ছি।
আর কতদিন চলবে এইসব, যা হওয়ার হয়ে গেছে।
যা প্রদীপের তো হয়ে গেছে।
এই দর্শক দেখতে গেছে ব্যাস।
আমাদের সেশনটা শুরু হচ্ছে।
Unmute করি, start. হ্যাঁ ঠিক।
মানব কই রে? মানব মানব কোথায়?
অশোকদা ভালো আছেন তো?
এটা কে দেখতে পাচ্ছি? ওইখানে দিনেশ বলল কোয়েশ্চেন আউট হয়ে গেছে, কোয়েশ্চেনটা আউট হয়ে গেছে, বই না হলে তুই কি রে
মানবদা কোথায়?
এখানে
দিনেশ কি লাইনে আছে? দিনেশ লাইনে আছে? হ্যালো, দিনেশ লাইনে আছে?
হ্যালো,
লাইনে আছিস তো? হ্যালো, শুনতে পাচ্ছিস?
মানবদা জয়েন করেছে নাকি?
হ্যালো
স্যার ইকোটা হচ্ছে আপনার মাইকে ঢুকছে ওনার কথা, আর আপনার কথা ওনার মাইকে ঢুকবে। কোনো স্টেশনে কিন্তু এরকম হয়। হ্যাঁ স্যার, আপনার কথা মাইকে যাচ্ছে।
ঠিক আছে, এটাই ভালো হয়েছে। দাঁড়া, কোনো অসুবিধা নেই। ও না না, মোবাইল ধরেছি, এটা ছবি। বল ডাক্তার লাভ ফোন করছিল, বলছিল কিছু বলছো
কেন?
কার আওয়াজকে? হ্যাঁ, আমি মোবাইলটা ধরে আছি, আমি মোবাইল ধরে আছি। আমি এখন মোবাইলে বসে আছি, টেবিল খালি হলে আমি বসে যাবো, তখন ফিক্স করবো। এখন হাতে ধরে আছি, ওদিক ওদিক করছি। মানবদাকে ধরেছি, মানবদাকে ধরেছি। মানবদা এখন রামপুরে একটা পেশেন্ট দেখছি।
কি হবে আর বৃদ্ধ বয়সে পেশেন্ট?
আমি ফোন করতে গম্ভীরভাবে বললো 9টা থেকে রাত্রি 9:30 পরে ফোন করো, ব্যস্ত আছি। বলার আগে কেটেছিল। এরপরে তো আমি আবার ফোন করলাম, ফোন ধরে না, আবার ফোন করলাম। এবারে বললো হ্যালো, কে কথা বলছে? আমি দুখানা ভালো ভালো বন্ধুত্বের অ্যাডজেক্টিভ দিলাম, বললাম আমি প্রতিজ্ঞা ও আমি ঢুকতে পারছি না, তো তোরা কি করেছিস? হোয়াটসঅ্যাপে নেই, আমি হোয়াটসঅ্যাপে নেই, তুই মেলে দেখো। তারপরে এখন আবার খগেনকে ফোন করেছে, তো পুরো ঢুকতেই পারছে না।
practitioners for inner surgery demonstration হয়ে গেছে।
হ্যাঁ
খাচ্ছিলাম আমরা।
হয়ে গেছে, তাহলে আমরা আরম্ভ করে দিতে পারি।
উনি কি জয়েন করতে পারছেন না?
হ্যাঁ,
মানবদা কি জয়েন করতে পারছে না নাকি?
দেখো জয়েন করেছে, হ্যাঁ জয়েন করেছে, দেখো তুমি দেখো জয়েন করেনি, কি বলছে এখন দেখ, চেষ্টা করছি।
চেষ্টা করলে
দিনেশ দিনেশ আমাকে আলফাল প্রশ্ন করবেন একদম
না। আমি
না,
তো
আমাকে জিজ্ঞেস করো হোয়াট ইজ অ্যালোপেসিয়া এরিয়াটা, আমি বলবো, বাদ বাকি গুলো অসুখ বলবো, ঠিক আছে?
এটা তো ফ্রেন্ডলি একটা গল্প আর কি।
আমার ফ্রেন্ড নয়, অল ফ্রেন্ডস আর ফোর। সারা পশ্চিমবঙ্গকে এক্সপ্রেস করবে আমি কতটুকু জানি।
কোনো ফান্দাবাজি কিছু নয়, একদম সিম্পল।
ডার্মাটোমাইকোসিস নিয়ে কি সব বই খুলে পাচ্ছে না, বইপত্র দিয়ে
বইপত্র খুঁজে পাওয়া যাচ্ছে না এখন।
দিনেশকে দেখেই মনে হচ্ছে যে আপ হিজ স্লিভস না, দিনেশকে দেখে, দিনেশের হাসিটা দেখেই মনে হচ্ছে যে
আমার সবচেয়ে সুবিধা প্রশ্ন করেছি, দাদারা সব
একটা চান্স পাওয়া গেছে। চলো লেট আস এনজয়।
পড়াশোনা করবো,
যে যা পারবে না আমি সব বলবো, বুঝলি প্রদীপ, যে যা পারবে না সবাই। এই ওয়েট করবি, মানব এলে সকাল
রামপুরহাটে কত পার্সেন্ট লেপ্রোসি পাওয়া যায়?
দিনেশ,
হ্যাঁ বলুন।
Dinesh, are you listening?
Yes, I'm listening.
Keep the difficult questions for Manav and let us start. Difficult question গুলো রেখে দাও, আমাদের স্টার্ট করে দাও। আর কতক্ষণ এরকম কানে লাগিয়ে বসে থাকবে?
ডার্মাটোমাইকোসিস কেসেতে কালচার করে কোন টাইপ অফ ফাঙ্গাসটা বেশি পাওয়া যাচ্ছে? ডার্মাটোমাইকোসিস। তুমি আমার প্রশ্ন করো, আমি এইগুলো ছাড়বো। হাভেলিয়া ক্লিনিকে কোনটা পাওয়া যাচ্ছে? কলকাতা শহরে কোন টাইপ অফ মিউকরটা পাওয়া যাচ্ছে, সেটা কোথায় কালচার করা হয়? সেন্ট্রাল এভিনিউতে অজিত বাজার বাড়ির অপোজিটে।
আমার ক্লিনিকে তো কোয়ার্ডিটাম লাগানো হয়।
দিনেশের পেছনে বই আর জার্নাল শুধু দেখ,
তাই তো বলছি,
বই আর জার্নাল কি জমা হয়েছে।
দিদির চেম্বারে দিদি ফাঙ্গাল কালচার করা হয়, জানো?
না
টপিক্যাল বন্ধ হয়ে গেছে, ওর ওখানে ফাঙ্গাস কালচার হচ্ছে।
না ও ট্যাগ দিচ্ছে দাদা।
আরে ট্যাগ দিচ্ছি কি, করোনা কালচার?
না আমিও তো কালচার নই, তো আমি তো হাইলি আনকালচার।
এই না, বোরিং লাগছে, আরম্ভ করি।
এই দিদি,
হ্যাঁ বলো।
আমাদের শান্তাদি,
বলো।
আমাদের দেবু সিং মারা গেছে, জানো তো?
হ্যাঁ
দেবু সিং মারা গেছে, খুব বিচ্ছিরি ভাবে ভুগছিল। এটা আমাদের কদিনের মধ্যে আছে।
আপনি লাইভে আছেন, আপনি লাইভে আছেন স্যার, আপনাকে
সব রেকর্ড হচ্ছে।
কতক্ষণ এরকম বসে থাকবো? হ্যাঁ, কেউ ছবি টবিও তুলছেন না।
এবার তো 2:30 হয়ে গেছে মনে হচ্ছে।
হ্যাঁ, কেউ ইন্ট্রোডিউস করবেন না, মানে স্টার্ট করবেন না?
ঠিক করবে বলে।
হ্যাঁ ম্যাডাম স্যার, আমি কি স্টার্ট করে দেবো তাহলে?
হ্যাঁ তা স্টার্ট করে দিন। মানবদা জয়েন করে।
জিজ্ঞেস করো দিনেশকে, হি ইজ দ্য
দাদারা যা বলছে, অশোকদা প্রদীপদা যা বলবে তাই হবে।
স্যার আমরা কি স্টার্ট করে দেবো?
হ্যাঁ স্টার্ট কর।
লাইভ একটু ওয়েট করুন, লাইভ যাবে তারপরে স্টার্ট।
তারপরে মানব পরে জয়েন করলে ডিফিকাল্ট কোয়েশ্চেন গুলো ওকে করবে।
ঠিক আছে এটা তোমার তো
মামলা করবে না তো 7 মিনিট আগে আরম্ভ করে দিচ্ছি বলে।
আমাদের গল্প মানে সেই কলেজ লাইফের গল্প গো। দাদা
প্রদীপ সব কিন্তু রেকর্ডেড হচ্ছে, প্রদীপ সব রেকর্ডেড হচ্ছে, কিন্তু রেকর্ডিং চালু আছে।
অল বেঙ্গলে সবাই শুনছি,
রেকর্ডিং চালু আছে।
Okay. Hello. Yes. Good afternoon. Good afternoon, everyone. Now we'll be starting our session, the Practitioners Forum. Will be a panel discussion, and the topic is very interesting. It is the wise man's woes. It includes recalcitrant dermatophyte infections, alopecia, and hand changes in housewife. The moderator for this round will be Dr. Dinesh Kumar Havelia sir. He is a renowned consultant dermatologist who has been the associate editor of recent advances in dermatology and author of RTKB Update. He is also recipient of many prestigious awards and has taken part in many conferences as judge, panelist, and delegate. He has been the organizing secretary of QTCon West Bengal 2009 and also has been a part of IDBL West Bengal as honorary secretary from 2010 to 2012. So now we'd like to start the session. Dr. Havelia sir, would you please start?
Should I share the screen? Huh?
Yes, sir.
Is my screen visible?
Yes.
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 So thank you, the organizers, for inviting me to moderate this session, and these wise gentlemen, which we always look up to for any pearls of wisdom, are our panelists. They're all renowned dermatologists of the city of Kolkata, and incidentally, all of them are ex-presidents as well. So this is my proud privilege to moderate this session. As you can see the name of these people, only two have given me the slides. So Dr. Ghoshal has done a DVD and MD from Calcutta University, and at present he is an associate professor in IQCT, Durgapur. He has been the past president and past secretary of IDBL West Bengal branch, also the past president of IMA Calcutta branch, and past editor of JIMA, JIMA. So another panelist is Dr. Pradeep Laha, with huge experience of clinical dermatology, and he has done MBBS and DVD from Calcutta again, and he is now a consultant dermatologist, Fortis Hospital, Kolkata. Dr. Shantadi hasn't given me her CV, but she's a very well-known figure in the city of Kolkata and very much loved by all of us. And she has a huge experience of clinical dermatology and particularly oncology part. And another panelist is Dr. Manobrata Majumdar, who probably has not been able to join. Maybe he'll be joining very shortly. He has also been the ex-president of our beloved association, and he has got a huge experience of clinical dermatology. And right now also probably he is practicing and seeing patients. So you can well assess that how busy he is as a clinician. Now we'll start our panel discussion. As already has been told that 3 topics will be discussed. So I'll start with recalcitrant from dermatophytosis. I would like to ask Dr. Ashok Ghoshal, what is the paradigm change in manifestation of dermatophytosis we are seeing these days in comparison to years? Say 10
Thank
years
you,
ago,
Dinesh.
and right now, what is the change you are noticing?
Thank you, Dinesh, and thank you, the organizers, for inviting me to join this panel discussion. In comparison to other years, for the last 4 or 5 years, we are seeing a huge avalanche of dermatophytosis cases in all the states of India, including the neighboring countries also, Pakistan and Bangladesh. So there is a huge rise in the number of cases. That is the number one change that we find. And the age group is also quite wider. Previously, we didn't have many children or very young, even infants. There were very few cases of dermatophytosis in them, but these days we are finding cases. And previously, we used to see mostly the young adults who are mostly involved in physical activities, sports and games, or they are spending long hours with tight clothing they were having. But now we find that lots of housewives in India, most of the houses wear very loose-fitting dresses, and there is not much of occlusion. As we say, occlusive dressing, which has come up in the past 10, 15 years. People are very fond of wearing jeans and tight tops, be it male or female young adult. That has also contributed to the number of rise in the number of cases. And previously, we could see certain areas of the body were more involved, like the intertriginous areas, the groin folds, the breast folds, the axillae, the buttocks. These were the common sites. But now we are finding tinea corporis in previously less involved areas and very larger lesions. Previously, the lesions were smaller. We are seeing many larger lesions with types of tinea implicated multiple margins. There is an advancing margin. Inside that area, we find multiple margins, active margins, which is also quite new.
Would you like to add something?
Yes, especially that all these infections. Hello, hello. Can you hear me? There is an interference going on. Regarding the spectrum of infection of the fungal infections which are going on, so dermatophytosis, are hello.
There's a very much background noise is there,
I think there is someone's mic is not muted. Anyway, can you hear me, Dinesh?
Yeah, we can hear.
Peculiarly, this mast-cell epidemic infection of dermatophytosis is limited to the dermatophytes only. There is no extra infection of candidiasis or with pertussis versicolor or some other types of superficial fungal infections. Why is it only limited to dermatophytosis? We don't know. And that too, not every species type of dermatophytes are involved. But all these infections, almost all of them are resistant to treatment. And this treatment, whether it is primary or secondary, is yet to be determined.
Sorry, I just want to know what are the change in manifestations you are seeing these days. Then we'll be coming later on all those points.
If I may add.
Yes.
Yeah. Lot of involvement of face these days, which we did not see earlier. And lot of inflammatory lesion, and also lot of changes in morphology itself. Fungus doesn't look like typical fungal infection. And there is no typical central clearing, which we used to see earlier. Rather, there is central scaling and confluence of the lesions leading to difficulty in diagnosis. It's like sometimes like seborrheic dermatitis, and even in face sometimes confused with acne rosacea. So change in morphology change in distribution, change in age group. These are the things, and a lot of inflammation, and very difficult to treat.
Yes.
Loss but
I'll
not
go to the
death.
next
These
question.
are the changes which I have seen.
What do you mean by recalcitrant dermatophytosis?
You're asking me?
Yes.
Recalcitrant.
I'm giving you the answer also. Huh?
Recalcitrant means recalcitrant. It's very difficult to treat. You keep on treating with the normal procedures and the schedules which are written in textbooks. You'll find after some time, after about a month or so, they are not improving to that expected extent, and then suddenly there is a flare up, and you have to start from step one with higher degree of dosages, or number of antifungals have to be added, and it becomes sometimes you have to cross the Lakshman Rekha and improvise. So unless we keep on experimenting without any set of guiding rules, we are experiencing very difficult to treat. So treatment of dermatophytes without proper response for a reasonable amount of time, it makes it a recalcitrant infection.
Fine, fine. Ashokda, when do we call it chronic dermatophytosis or recurrent, or whether it's a relapse? I mean, how will we stratify all these? Dr. Ashok Ghoshal, can you hear me?
For chronic dermatophytosis, if a person who is being treated for a considerable time and does not get cured in spite of treatment for 3 to 6 months, or even 1 year with multiple courses of treatment, we should call it chronic dermatophytosis. Recurrent, if a person is cured for some time and devoid of symptoms, and then it comes back, then we call it recurrent.
It comes back within 6 weeks, less than 6 weeks. And relapse, we call it after the treatment, after 6 to 8 weeks it comes. It's hardly of theoretical significance. So, what, according to you, could be the reason for such explosive incidents? Hardly it has been discussed, but still, any points to add?
Could you repeat the question again, Dinesh?
What, according to you, could be the reason for such explosive incidents of dermatophytosis in India?
There are various things. Number one is the layman's self-treatment or the shopkeeper's treatment. The inclusion of multi ingredient creams and ointments used injudiciously by the patients by themselves, or written by the GPs, or written by sold by the shopkeepers, which invariably have steroids and antibiotics in them. Now they give an instant relief in 2-3 days, which is very gratifying to the patient. But after some time, when the relapses come because of the prolonged use of the steroids, a repeated use of these ointments, it comes in a peculiarly different form. So it can become as an incognito, TDI incognito, or any other form. And then it is beyond the scope of the general practitioners to treat them or diagnose them. They are sending to us. We also take some time to come to hit the nail on the head, and so it becomes a very problematic issue.
Yes. What
One
would be
point
that?
I would like to mention here.
Yes.
Please I would like to highlight one point here. For last several years, say about 10-15 years, there has been a tendency of people choosing antiseptic soaps over normal soaps, like Dettol, Savlon, etc.
Exactly.
In that way, we are actually removing the commensals from the surface of our body.
Correct.
Mostly protective, because the whole field is remaining bare for the fungi to invade. We are getting more cases of fungal infections because the protective coating of commensals is not there.
Another thing I would to add is the upliftment of the society and the modernization and sophistication of the societies at large, with the influx of the shopping malls, from where people are rampantly buying clothes after they wearing in the trial room. Now, what happens, everybody knows that you try on 4 or 5 dresses, buy 2 of them, leave 3. And then this goes on for 3 or 4 times till the 3rd dress is bought. Now, we as an Indian, we usually wear new dress without washing. Because our concept is that once you wash, it becomes old. So, we are wearing that new dress previously worn by 3 or 4 customers, and especially ladies who wear it, try it on their body. And when they are using it for the whole day after buying it, they are inviting that fungus which is there already to invade their skin. So from my experience, I'm finding lots of youngsters and people of the lower middle age, they are getting this sort of infection from the trial rooms of these uh, shopping malls. You see?
Yeah.
The other thing is also 5-star hotels swimming pool, because people have a tendency to enjoy the swimming pool and wear the swimming costumes and towels provided by the 5-star hotels. They don't take their own things. Now, obviously, these are not sterilized or boiled. They are just washed and kept on the folded and kept on the rack. Obviously, the people who have used it before, if they have these things, they are this is spreading like wildfire among the next users. So these things have to be spread in the community, this awareness that these things should not be done.
Yeah, apart from these other predisposing factors as I have shown.
Yeah, may I add something?
Yeah, Shantaji can.
The reasons for changing epidemiology can be broadly divided in 3 groups. It's the pathogen itself, the host factor, and the environment. There is a species shift in the zoophilic group, which is more virulent and more inflammatory response. So all the work is pointing out to the great work of Shomo and others, the great Indian epidemic. It says that Taenia mentagrophytes is the causative factor, and there is dormant fungi sometimes, role of biofilm, making it more resistant, and host factor, there is lot of obesity in the community, more diabetic patients, atopy, immunosuppression due to several causes, lot of broad spectrum antibiotic use, making patients more immunocompromised, and also the environment and as a whole the lifestyle, as Pradeep has mentioned, and also the agricultural field using lot of antifungal, and that is also contributing to the environment. So that is also causing more difficult and resistant variety, and this is causing difficulty. And also international travel, migration of people, so all these things, overcrowding, urbanization, everything has been actually responsible for this outbreak.
Great.
Dinesh, may I ask one question from my side, that regarding this resistance and the peculiarly 1 or 2 species, like Didi said, Taenia mentagrophytes, which are spreading, which have become resistant and which are spreading the disease. Could we think of any sort of mutations of these genetic things going on? Now, these mutations, could it have been like corona, been an experiment which had been done by some quarters to spread the disease in the third world countries only? Why isn't it happening in any of the warm Western countries at all? This is a question which is popping in the mind.
There is now one particular Indian strain has been discovered. I don't know the exact name of that, but there's one Indian strain which is very much prevalent in our part of the country. And that is also adding to the burden of this dermatophlebitis. Apart from all these, and maybe topical steroid misuse, as you have already told, and maybe we are treating suboptimally. That may also lead to resistance.
Yes.
So what we do is we copy Western books recommendations on the treatment of Taenia, which is probably not right. So we may
correct.
So how do you manage extensive dermatophytosis? I think anybody can take. Nowadays, how do you manage?
In extensive dermatophytosis, we have to go for systemic as well as topical therapy, and counseling of the patient. All these things we have to consider, and we have to inquire about involvement of other family members or close contacts, sexual partners. They have to be treated as a whole. All the members affected in the family or the close acquaintance or close roommates in the hostels or barracks, they have to be treated simultaneously. Otherwise, we cannot eradicate the infection, or even if we can cure the person for a short time, he is going to be reinfected. And regarding topical preparations, we have many choices, starting from clotrimazole or cyclopyroxolamine, iverconazole, oxyconazole. These are there for quite a long time, and we have used many of the molecules, and fluconazole, which has come up recently. And regarding efficacy, some of them show a little edge over the others. But to be very frank, clotrimazole or miconazole or luliconazole or iverconazole, when I use them in different patients, I don't find much of a difference or failure or higher success in other groups. Most of the time we use in combination with systemic therapy also, which started in our younger age with bisulfalvin. Then we had ketoconazole, we have carbinafin, and then itraconazole. And I'm not going into the voriconazole, posiconazole, etc., which are usually reserved for systemic infections. But for superficial dermatophytosis, we can restrict our discussion to these things only. Bisulfalvin, carbinafin, itraconazole, and fluconazole.
They advocate rule of two. Rule of two means when you apply topically, you start from 2 centimeters beyond the margin of the lesion, and you start applying from
centripetally. It has to be applied centripetally, starting from about 2 millimeters outside the margin of the outer margin of the lesion,
and continue 2 weeks beyond the clinical cure. Whatever systemic therapy you are using, 2 weeks beyond the clinical cure. Ecological cure, we sometimes this is.
Yes, that is true. I usually ask my patients to keep on applying and taking the medicine for 4 weeks, because I usually counsel the patient on the first day and let them understand the fact that this is a plant source of infection. That is the layman's way of conveying the message. So the roots are deep into the skin, and we can clear off the superficial part very easily, but the deeper part has to be cured till I'm asking the patient, I ask the patient to continue till I ask them to stop, because as soon as the sweating starts, they will come back again. Number 2 is that I ask them to boil oil clothes. I ask them to wear thin cotton airy clothes, and every day boil for 15 minutes in plain water and then wash with detergents. This is mandatory. Unless we do this, the things will recur and keep on recurring from their clothes. This is I do.
What are the other advice you give to the patients? I mean, counseling.
Sorry?
General advice you give to the patient, apart from boiling clothes.
Other than boiling clothes, you have to keep a distance from your own partner and from your children, and you have to avoid applying soap from that area directly. Nowadays, what I ask them to apply is an antifungal shampoo literally all over the affected area and the body. Keep for 5 to 10 minutes and then wash it off. It serves 2 purposes. One is cleansing of the body, and number 2, whatever little amount of antifungal activity it can add, it will act. And the patients are satisfied because the bodies are clean. Now, over and above that, I ask them to liberally apply the ointment or cream of choice. I prefer gel form because it works better in the active cases. And whatever the dose is there, but I will ask them not to miss any dose, whatever it is. Okay. And I prefer to give 2 antifungal orally. In a moderately severe case, 2 antifungals of different strains, say terbinafine and fluconazole, in a combination stage, and keep on till the reasonable amount of clinical cure is there. Then I can withdraw or lessen the dose of one and continue with the other till about 6 to 2.5 months. And then, according to the case, I withdraw or stop. Okay. this is the schedule I follow.
Yeah, so Ashok, any other advice apart from what has been discussed?
What we are finding these days that the initial dosage schedule that was recommended is inadequate. So often we have to start with a higher dose, almost
Exactly.
double the dose which was recommended initially. Like terbinafine was recommended 250 milligram, one tablet daily is enough. But we find that at least one tablet twice daily has to be given. And the length of treatment, which was previously recommended as 3 to 6 weeks, has now gone up to 6 to 12 weeks.
Yes.
But we have to keep in mind that we have to monitor all the time because we are using higher doses and for longer period of time, we have to monitor and we have to impress upon the patient the necessity to go for the investigations that we suggest. So, dosage.
Right. So, Shantadi, how do you handle tinea in pregnancy, extensive tinea in pregnancy?
Yeah. Pregnancy, none of the drug is declared safe, so have to be local application only. And that is why mostly trial and error, newer antifungal and personal hygiene plays a major role. And also, which I observe here in our area, that people contract infection after the delivery from hospital itself. People who were naive before. So with children, that poses a real difficult situation. But that has to be only local application and personal hygiene. Have to counsel the patient very carefully. And also the fomites are also the familial dermatophytosis is coming in a long way. So all the family members to be screened and the hidden parts to be examined, particularly the nails. And all the fomites, we should not forget the bed linen towels because it survives in towel for 9 months, it says recent study. So, and hope for the best till the child is delivered. Even during breastfeeding, we'll have to be very cautious. So oral antifungal is a big no. So pregnancy have to be tackled with local antifungal. And also the brand, I should mention, the Ashok and Pradeep has said very comprehensively about the treatment. But the brand is very important because the number of pellets and all that, actually there has been studies. So choosing the brand is also very important for efficacy.
What about in elderly, Ashokda?
Sorry?
In elderly, how do you manage?
In elderly, it is difficult because most of the elderly persons will be suffering from comorbidities and they will be on other medications also. So you have to consider, to begin with, we have to monitor their liver function, kidney function, diabetes. If they have coexisting thyroid disorders, whether they are taking PPIs, antacids, etc., because that will also interfere in the absorption of the drugs that we are prescribing, and drug interactions. Whatever drugs they are taking, we have to consider that. So we have to monitor them more cautiously, more frequently. Perhaps in a young adult, I would have advised the person to have the blood test done after 6 weeks, but for an elderly person, I would advise LFT, urea creatinine to be repeated every 3 weeks. And we have to consider about the drug interactions. Whatever drugs they are taking, neurological drugs, antihypertensive drugs, anti-diabetic drugs, or there are so many drugs which have interactions with terbinafine and itraconazole, more so with itraconazole. So in elderly, I basically prefer terbinafine over itraconazole for their lesser drug interactions and lesser hepatotoxicity.
You would like to add anything? Children, how do you manage, Pradeepda?
Hello, can you repeat it?
Dermatophytosis in children.
In children, well, children is a very big spectrum. It starts from in neonatal age till nowadays 17, 16, 17 years.
12, 14 years, up to 14 years maybe.
Up to 14. Up to 14 means, well, there it is, I would prefer not to use or minimally use the oral antifungals and teach them and educate them about the personal hygiene, and with the parental guidance, parental counseling, depend mainly on the local applications and certainly we can use fluconazole, but fluconazole has to be given in a proper judicious age-related dose so that it works. Terbinafine can be given, but I think it is better to start after 9 or 10 years. Isn't it?
After 2 years of age, it can be given.
After 2.
After 2 years of age, terbinafine can be given. We should avoid fluconazole. We should avoid systemic therapy if we can manage.
Yes. Another thing is that regarding fluconazole, previously what we were taught was once in a week 100 milligrams. Definitely that is very much underdosed nowadays, and then it came to twice a week. But what I have found, I got the courage from studying what the medicine people give. They give Cystan IV daily.
Yeah, they give in oropharyngeal candidiasis.
So, medical problem. My point is that if the patient tolerates it well, without any side effects almost, in all cases, then why can't we give it orally?
Yeah,
you understand?
50 mg.
So, no, what I gave is that 100 milligrams daily.
Fine.
Keeping, of course, the liver function test done for 2-3 weeks. And once it is controlled, then I can take up the dose. But definitely, I have not found a single case of hepatotoxicity or any other problems till date, although I monitored them. So I think we can increase the dose to 100 milligrams daily. That will be safer and more effective.
This investigation part has been already discussed. This also has been any role of salicylic acid, moisturizer or powder in tinea. Santadi, you can take up.
Salicylic acid in finger waves, it's much better, and in the area where is hyperkeratotic, it may help for removing the scale and turnover. Moisturizer definitely, because there is defective skin barrier, so moisturizer will be better. But antifungal powder really doesn't help, and low dose antifungal also increases resistance to treatment actually. So soap and antifungal powder should be avoided actually. And moisturizer, of course, moisturizer helps because the skin is already damaged, so it gives a soothing effect, but should be used in different time, not with the medication itself.
Yeah,
different time which will repair the skin, and there will be better outcome as a whole.
But I beg to differ, Santadi, that the more you moisturize the skin, the more it becomes prone to fungal multiplication. So I think it would have
depends on the moisturizer itself, because there are varieties of moisturizers in the market. So we'll have to choose it accordingly. Because
no, it's not a question of the varieties; it's a question of the principle. Because if the screen becomes soggy and damp, then you are inviting the fungus to multiply and grow. So we have to keep it as far as possible from, just like we ask them not to wet the skin too much. Keep it soaked.
But this is the recommendation from the expert committee, that it prevents the epidermal water loss and improves the skin barrier function and ultimately improves the weight.
I think it's a Western model. We have to improvise according to the humid climate of our country.
You can avoid it in groin and under breast.
Obviously, we have to be very careful about that.
Open part, you can always use, and actually I use it with good result.
Ashok, any
rule of salicylic acid, I would like to add one or two things about salicylic acid. Planter and farmer involvement with dermatophytosis can lead to very thickened keratin layers, Mocassin pit, as we know. In that case, we can use salicylic acid along with antifungals to help them get a better penetration, and also helping in removing the thickened squamous cell layers. But it should be specifically avoided in intertriginous areas.
Correct.
We have to ask the patient to apply salicylic acid containing preparations or salicylic acid known preparations on top of the antifungals only in case of hand and foot involvement, but in the groin and other areas it must not be used. And regarding moisturizer, in our country, when we are living in a very hot and humid environment, moisturizers is not a recommendation in treatment of fungal infection. In the Western countries, when they are in a very dry climate, cold climate, and the skin wrinkles or dries up or cracks and gets fissured, there they may ask for moisturizers. But in our country, most of the time, on the glabrous skin or on the intertriginous areas, there is no point in applying any moisturizer. And powder usually occludes the hair follicles and sweat gland pores, and that may lead to secondary bacterial infection and folliculitis. So that also should be avoided.
Only indication of powder is in prophylactically it should be used in tinea pedis. That is the only indication of powder.
Dinesh, I can't hear you.
Only indication of powder is that. Can you hear me now?
The voice is breaking.
Yeah, only indication of powder is tinea pedis. It is to be used prophylactically.
Interdigital, intertrigo. Only there you can use it.
That too, it will absorb the sweat, that's all. It is the physical character of the powder which is acting. No amount of powder can go into the skin, or the powder which is soaked in antifungal cannot ever enter the skin to act against the fungus. It is the powder. Whatever powder you use, it will be active over there.
Yeah, fine. So any role of oil, many people advocate oil also. I just want to be clear about it.
No, I think that aggravates the situation.
That aggravates the situation, yes.
I advise not to use.
It may relieve the itching. It may relieve the itching or scaliness, but actually it provides more food to the fungi.
Correct.
Now we'll change the topic. We'll talk about hair loss. So what are the common patterns we see in male pattern hair loss? Pudita. So it's very commonly seen.
Well, what we find is a frontotemporal recession in the males, and with various degrees. That is the most common, and for the females, it is the vertical hair loss which is most common nowadays, more due to hormonal changes, mainly PCOS and lifestyle changes which is going on nowadays. I think sleep loss and too much of work pressure somehow has a bad effect on the female type of alopecia, which I think every college girl or every working woman almost is suffering from. I would like your opinion on this.
Now, what I think, the maximum number of hair loss patients who are coming to us, these days we are having very young patients, both male and female, accompanied by the parents, and they are coming and telling that the boy or the girl is losing a lot of hair from the frontal region, particularly on the two temporal regions. Actually, our perception about the normal things that happen in our life, in teenage, we start growing hairs on our cheeks or mustache on our lips, and there are many other changes in our body. People accept the good things, but they are not ready to accept the other things. Like recession of frontal hairline is a feature of adulthood. In the teenage, you will have the recession of the frontal hairline with bitemporal type of recession. It is quite common, but people are not ready to accept that now. They find this to be a complaint to be made of and go to the doctor to seek treatment and prevent this normal thing. And most often we have to convince them that this is a very normal thing. Bitemporal recession or frontal recession in the teenage group, particularly in the later teens, is a very normal thing that we have to convince them.
Their conception of hair loss is inadequate and wrong. Just if patients already always come to us with say that 10-15 hairs has been lost every day, that goes on in 100 days. So many hairs will be lost by the time 1 year passes, he'll become Anupam Kher. So we have to tell them that every day the normal amount of hair loss is about 100 per day, and for that we don't need to get any treatment done. So this type of counseling and education we have to do. Most of them they are satisfied with the counseling, but there are some who always keep on doctor hopping, or they search the net and land up in a miserable condition. So counseling and educating them is very important.
Okay. Now, next question. Santadi, how do you differentiate AGA with telogen effluvium? Santadi, can you hear me?
To whom are you? To whom are you?
You can take this question. No, I'm giving you the answer as well. Differentiating points between androgenetic
Santadi, go on.
and telogen effluvium. Maybe she had lost connection. She'll rejoin it. So Ashokda, you can take up this question.
AGA, androgenetic alopecia, has got its pattern and it has got its timing. It starts usually in the late teens or early 20s, gradually increases, goes on up to the age of 40, 50. So that timing is there. Whereas telogen effluvium can happen at any age, at any point of time because of certain precipitating factors. Most commonly, some sort of illness, and course in the AGA is ongoing. If you don't, it will go on up to a certain extent and it will stop when it reaches that point, and beyond that, the ring of hair will remain there and the rest will be gone. Whereas in telogen effluvium, it is a short span of time. It starts suddenly, continues vigorously for a certain length of time, then gradually it again subsides, and normal hair growth starts again after some time.
Fine.
And shedding in AGA, it goes on slowly over the years. So you don't notice the hair falling. You don't see it on the pillows or in the basin like that, or in the bathroom floor. Whereas in telogen effluvium, patients collect the hair they lose every day and show them to us, and there is a lot of hair bundles they carry with them in a plastic bag to show us. Yes. So AGA is a slow process, ongoing process over years, whereas telogen is a short time, regular loss of hair.
Another point is the history. From telogen effluvium, if you take a history, it is always within last 1.5 months or so. Before that, they give a history of some severe disease.
There is a definitive precipitating factor.
Precipitating factor for that. That is true. And telogen effluvium is always in the telogen phase.
Fine. How do you approach a case of hair loss? Though we have already discussed.
Counseling. And
absolutely. Counseling the parents
and the child.
Not only the child.
We are not going into it.
Either the husband and the wife also.
Now, how do you handle the patients of post-COVID hair loss? These days, every day we are seeing 4-5 patients per day. So how do you counsel them? Pradipda, you can take.
How do I counsel how do I counsel the patient? I think Didi is trying to say something. Please ask Didi to unmute. I think she is muted. Didi, you please unmute.
Shantadi.
Someone ask Didi to unmute, please. Hey, এখান থেকে অদ্রিজা শান্তাদিকে আনমিউট করতে বল।
আনমিউট করা যাবে? শান্তাদি মিউট করে বসে আছে।
শান্তাদি
Dinesh, you can unmute Shantadi.
I can do that.
Yeah. You're on the screen.
So in post-COVID hair loss, again, the main thing is counseling. We have to explain to them that you had such an infective disease and your hair follicles, many of them anagen hair follicles, they have been damaged, and the damaged anagen go to the next phase, telogen, and then they go to catagen. Then after 2 to 3 months, they start falling off. So from the day of your illness, hair loss starts about 6 to 8 weeks after the severe illness, and that will continue for 3-4 months, and gradually the hair will again regrow. We have to reassure and explain the whole thing to them, and in addition to them, you will have to give something to them, otherwise the patients will not be satisfied. So we mostly give some vitamins, supplements, vitamins and mineral combinations with biotin, and we give some sort of topical applications, preferably procapixil, minoxidil procapixil combination or capixil.
But
That sort of some medications has to be given, otherwise the patient will not be convinced and they will not be satisfied. But we have to explain to them that this is the problem and reassure the patient as well as the accompanying persons, maybe the parent or the spouse.
And we can undertake few tests also, like routine blood tests, ferritin and
Hello, এখন শোনা যাচ্ছে দিনেশ?
Yes,
Am I audible now?
audible. Okay.
Am I audible now?
Yeah, you are audible.
ma'am, you're audible.
আচ্ছা, হোস্ট মিউট করে দিয়েছিল, আমি কিছু করিনি।
The Shantaji, COVID hair loss, your favorite topic. Tell us something about
না, we have to check that whether the hair fall was pre-existing problem or it just happened. So assurance is good enough. That will be good. And the treatment to help and counsel, and whether there is any associated disease, whether there is full recovery, we'll have to check that. And also iron replacement, because there is a ferritin deprivation during COVID. So that is another important.
And even vitamin D also they say.
Vitamin D.
Particularly
actually, when the patient is suffering from COVID, the physicians consider all these things and they also estimate ferritin, vitamin D, B complex, B12, all these things are usually done normally.
Yeah, already done.
And it has been seen that this COVID-19 virus itself also causes hair loss by 2 or 3 mechanisms. Apart from this telogen effusion mechanism.
And the COVID positive hair loss is literally profuse. It's so profuse that when it comes, they come with ball, when almost hair balls as big as a table tennis ball. And you can literally see the test. You don't have to pull, you just have to put your fingers through the hair and you'll find that so many strands are coming out. It becomes very weak. So naturally it becomes a very psychological problem.
Hand holding is the most important. So what is the advice you give while you prescribe minoxidil to the patient?
Minoxidil is something I somehow detest from advising.
No, not because in COVID, for male pattern hair loss or whatever.
I counsel the patient. Also, which is what?
We have, we have to tell the patient how much to apply, not more than 1 ml at a time. Preferably 6 to 8 drops I tell my patients to apply on the scalp and not on the hairs. So after bath, dry the scalp as far as possible with towel and then with a blower if you can, or I ask the patients to put the fingers inside the hair and shake them thoroughly to get it as dry as possible, and then apply 5 to 8 drops of minoxidil solution on the affected area, taking care not to trickle down on the forehead, and no massaging, no rubbing, just gentle application for spreading the lotion over the affected areas.
Another very important is
may I speak?
Yeah,
may I speak?
Yes.
What I tell my patients is that, look, this is some procedure which definitely has its good effects. Hair will definitely grow, but it will be there till you keep on applying. So whatever happens, whether the sun shines or the moon comes up, whatever happens, you got to keep on applying every day. If you give a gap of say 15-20 days or 1 month, the new hair will fall off and some older hair will also go. So you have to understand this is a lifelong procedure, and the percentage of minoxidil will have to be built up. And number 2 is that, as Ashok said, this very small amount, exact amount has to be applied, not with the fingers only, but gloved fingers. Initially, when we were doing our post-graduation and all, there was a company used to called Groom, who used to sell the product as Groom. They used to supply hand care gloves with it, so that it is not absorbed through the fingertips, because basically we have to remember that this is an anti-hypertensive drug. So if too much is absorbed, whether it's to the fingers or the scalp, it may cause a drop in blood pressure. So these things are first thing which are a primary thing which I educate my patients, and then when they accept it, I prescribe.
Shantaji, anything, any addition?
It will be a good idea to do a patch test because some people may be sensitive to it, and also caution about hypertension, and not to put the hand on face. So there will be growth, particularly in female patients.
Another important point, we should forewarn the patient that there will be initial telogen effluvium after application.
Yeah, that Pradeep already has told.
Yes.
Otherwise patients will not trying to apply. I mean, they will not comply with the.
No, Pradeep has mentioned that actually.
Yeah,
That's
fine.
why I did.
Another thing I would like to mention here, whichever preparation you apply, most of the preparations, they dry up on the scalp and form a film. And there is a uneasy feeling on the scalp, and there may be irritation also. And the patients, because of the excessive scaling, the dry flakes that come up, they find that they tell that they are having dandruff after applying minoxidil. That we have to explain that this is a medicine that you are applying that is drying up and forming flakes. And that's why you have to wash your scalp every day. Because these days I find most of the girls and women, they don't wash their scalp every day. They have a habit of shampooing only once a week or twice a week. Rest of the days they do not put water on their scalp. So you have to make them, convince them that they have to wash away the minoxidil that they had applied yesterday to apply again today.
Great.
Washing of the scalp
This problem, this is absolutely true, Dr. Ghoshal, and I tackle this problem in this way, especially ladies. They say that if I wash my hair every day, the hair will keep on falling too much, and I'll be scared, and I'll develop this thing, dandruff and whatnot. So I tell them two things. One is that when in this sultry climate of the coastal areas of India, you're washing your face 3 times a day with water, and you're washing your head once in 3 days. So then you come to one reason, one logic. You wash your face once in 3 days, like you're washing your head. Immediately then you say, no, how can it be done? And then if this cannot be done, then that also cannot be done. So if you have to wash your face 3 times a day, you have to wash your head once a day at least. And remember that ladies who are swimming, they wet their hair and they damp their hair every day for 1.5 hours, and nothing happens. No extra amount of hair falls. So naturally, this misconcept of not washing your head every day has to be corrected in this way.
Minoxidil and oil, how do you tackle? Many people want to apply oil also, and you have prescribed minoxidil. So what do you advise them?
If someone is very keen on applying oils and there is sometimes peer pressure or family pressure, the mother-in-laws insist that the daughter-in-law has to apply oil on the hair so that the hair remains on her scalp. So in that case, I advise them to apply oil 1 hour before bath and wash it off at the time of.
What they say is there should be minimum of 4 hours gap between minoxidil and oil. Minimum gap should be 4 hours. They are very keen. Any rationale of various combinations of minoxidil?
Questionable. Everything is questionable and not very much established. But when you see a patient for years and he or she comes to you every 3 months or so, after 2 or 3 repetitions, you have to change your prescription. So it is better to have some choices.
Yeah, as an art of medicine. Right.
That is the art.
What are the minimum investigations you do in a case of hair loss? I think we have discussed this already.
Yeah, hemoglobin, thyroid,
all those we have discussed. We have to take drug history also. This is very important.
Ferritin level is very important.
Very important.
Many cases we find deficiency over there, and certainly if it is a very resistant in females type of lipiture, you have to go for a hormonal profile with the idea of if it is a PCOS, then you have to investigate according to them. Okay.
How do you handle this finasteride misinformation to the patients? The moment you prescribe finasteride, they will come back and say, doctor, I'll have this, I'll have that. How do you handle that situation?
This happens mostly with systemic finasteride or
Systemic, I'm talking about it.
But in topical application, it is not that much relevant.
No, I'm talking about oral finasteride. Oral finasteride.
Finasteride 1 milligram tablets.
Yeah. When the moment you prescribe 1 milligram finasteride, most of the patients will come back, read Google and say, I'll have sexual problems, I'll have this, I'll have that. How do you counsel them?
Actually, 58% patients improve on their own. So have to counsel them properly. And if they're reluctant after stoppage, the function will come back within 3 months. Have to be assured about that. So if they pursue with the medication, 58% doesn't have any problem afterwards.
In any case, the positive effect of finasteride goes on for a few months only. After that, a plateau is reached. After that, however you may increase the dose or whatever happens, finasteride will not improve its effect.
This happens with minoxidil also.
Same.
This we have discussed. Any comment on oral minoxidil? Any one of you have tried?
No.
No idea.
No idea.
You give us a light, give some sunlight on it.
It is coming in the market now. It has already come. And those in males is 1.25 milligram per day. It is available in the tablet form, 2.5 milligram. You can cut it into 2 halves and take 1.25 milligram per day. And in women, you start with even a lower dose. Start with 0.25, go up to 2.5.
In which areas of the body the hair will not grow if you take oral tablets?
There may be some hypertrichosis on the facial area in around 25% cases, but they are not so much bothersome. As they say, not too many people discontinue the therapy. And you have to keep this minoxidil topical application also on along with the oral minoxidil till the oral minoxidil takes its action fully. Then you can withdraw topical minoxidil. And the side effects are mainly hypertrichosis, sometimes tachycardia, pretibial edema, postural hypotension. You have to keep that in mind. Explain to the patient also. And you have to.
And how long does it take the hair to restart growing?
Around 2 to 3 months.
6 months.
Minimum 6 months, but minimum 2 to 3 months to show action.
Is this a lifelong procedure?
Minoxidil, when minoxidil is there, it is a lifelong procedure. But it has been prescribed by many abroad. Now, many are using in India also. Alopecia areata, when you encounter a patient, how do you understand that this alopecia areata will have?
Sorry, sir, to interrupt. We are really running.
Right, I know we are. So we'll bundle up this fast.
Sure, sir. Sure.
Few points on homemaker's hands. Third topic. What are the changes you see in homemaker's hands? Also, that you can take.
Firstly, there is thickening of the skin. Palmar skin is thickened and hardened. And the palmar creases are more deep and they are more pigmented most of the time. And there may be slight flakes and scaling on the palms. That is also aggravated near the palmar creases. And there is cracks and fissures at the fingertips and the ball of the thumb, just at the base of the thumb, the part of the palm adjacent to it, that becomes quite thickened and multiple creases and fissures may appear over there.
Okay, Dinesh, we have to wind up now.
I'm just winding up.
Yeah.
I think we'll wind up. Everything has been discussed in great detail. I'm really grateful to our wise men. Their pearls of wisdom have given us a lot to think
wise men and the lady.
And
you should mention the lady.
Thank you, Dinesh, for conducting it so well.
Thank you, Dinesh.
Thank you very much. It was very informative. Thank you. It was a pleasure.
Thanks to the team.
Thank you.
Bye. Thank you, speakers.
Thank you, Dinesh. Thank you, Pradeep. Thank you, Ashok. Thank you, Shamit.
Thank you, Didi. Thank you, all of us.
Thanks to Sumit and the team. Okay. Thank you very much.
Thank you, everyone. We are wrapping up the session now. This was the last session. Thank you for attending. It was a wonderful session, sir and ma'am. Hope to hear from you soon again.
Thank you, Dr. Pratik, for conducting it
Thank
so
you.
well.
Thank you, sir.
Thank you,
Thank you,
Dinesh.
Didi. Thank you, Kudipta.
Thank you. Congratulations to you, Dinesh.
It was quite,
Lovely
quite
question.
enjoyable. Quite enjoyable.
Okay, bye. See you in QT Con.
See you. Bye-bye.
Bye.